All right. Well, still some people coming in here, but in the interest of time, I'm going to kick off the opening remarks here. Lest everyone should rest assured, the meat of the content is coming later, so I'm sure Zoom will let everyone in. But welcome everyone to a set of panels on lessons for U.S. health reform, ideas from healthcare around the world. Thank you for joining us. Good morning, or this is a truly national and global audience, so hello. I guess I'll be time zone agnostic. A quick piece of housekeeping. We have closed captioning available for those who want it, so you can turn that on in Zoom if you'd like. And without further ado, then I'll dig into opening up a little idea for everyone about what we're trying to do here today in a slightly new format for a meeting. And one that we hope, brings the best out of Zoom since we've had to deal with it for so long. So to motivate what we're going to be talking about today, I want to start with some of the requisite graphs. And many of you will have seen these things many, many times, which is some version of cost. But today we're going to be thinking about ideas for making healthcare more effective, more efficient. And that's really two sides of the coin. There's quality and there's cost. But I want to start by just noting the level and growth of US healthcare cost as a share of GDP. And it's actually gone up a little more even since this, but it's approaching 20% of GDP. So north of 18% of all US GDP is spent on healthcare. And that's not just a high level, it's been growing quite dramatically for some time. And that brings us to what we're trying to do today. It's certainly the problem in many ways, but it's also the opportunity, which is that we've had tremendous gains in terms of life expectancy and life quality improvements. In fact, many of you may have been vaccinated by some of this technology. These are tremendous improvements. On the other hand, it's an incredibly expensive system. And there's ways that things could be done more effectively. And that's really what we're trying to think about today. I'll talk about how we're trying to think about them today in maybe a slightly different way, since we're not by any means the first to be concerned about this. But since this is considering across countries, I also want to paint the picture of the US healthcare system, not just by itself, but relative to a comparable country average. And a couple of things you'll note here. This is from the OECD data. So you can see each country as a little gray line, but the average there is blue. And what you'll notice is particularly the big gap. And we want to think about that, not just in sort of stating that it's large, but thinking about what drives that difference and the trade-offs of closing that or not closing that gap as we think about different health reform options. But you'll notice that there's about 7 percentage points of additional GDP spent in the US on healthcare compared to an OECD country average of comparable countries. So that's a lot of money. We could do a lot with that. Some have argued we could effectively end poverty if you were to repurpose that. So it's certainly not a trivial amount. On the other hand, we get a lot from our healthcare system, and that's really kind of motivating what we're trying to do today. What I also want to note is not just to talk about the US's exceptionalism in cost relative to the rest of the world, but also talk about how these things are actually converging. And there I want to not just look at the level, which is a big difference, but the growth rate. And I want to note something pretty interesting, at least I think, which is the story going back to the 80s was that the US was both spending a lot on healthcare and it was growing a lot faster. But since then, in fact, growth rates in comparable countries have become much more in line with the US. And this reflects a broad view that much of healthcare cost growth comes from technologies that all countries would like to access given enough income. And so I think this also reflects an opportunity from what we're talking about today, which is to say that the US is not the only country dealing with healthcare costs, as we're going to hear time and time again, and that both at an aggregate level and then particularly at a micro level, when other countries come up with innovations, be it policy, be it organizational, be it financing solutions, there might be a lot for the US to learn from them. And that's really the heart of what we're trying to do today, is start that conversation, not just about one country versus the other, but about what innovations and solutions we might learn from in thinking about effective solutions for US healthcare. So I've talked about cost, and I've already tried to note that cost in and of itself isn't bad. We get something for it. So I also want to talk about quality or outcomes. And that can be done in a lot of ways. Very commonly, it's talked about in terms of life expectancy, but really life expectancy comes from a myriad features, not just the healthcare system. And I want to note kind of one of the really interesting efforts to look at cross-country comparisons of a very important measure of health outcomes. And here, this is work from AJ Policy a few years ago, but this is deaths per thousand live births. So this is infant mortality. And what you'll notice, and here we're comparing the United States to Austria and Finland. Finland turns out to be the lowest infant mortality of any country in the world, and Austria is not far behind. So sort of the kinds of comparable countries we're going to be thinking about today. And what you'll notice, which is quite interesting, is that the US cumulative probability of death within 1 year is dramatically higher. So to put it in perspective, this is close to Colombia as a country. So the US relative to GDP performs very poorly on this, and that's been noted time and time again. What you'll also note is that actually that difference when people leave the hospital is not very big. And in fact, that difference grows dramatically, largely outside of the healthcare system. So I'm just posing this interesting point here in this question about, well, the healthcare system, and we need to think about health holistically. And that's a particular domain where some of the countries we're going to think about today have also considered how their healthcare systems integrate with other social safety net systems, with society as a whole. What I also want to note in thinking about where we're going today, in trying to understand how the US might make effective changes to the healthcare system to lower cost, improve quality, or both, is if we break this same graph out by by advantage level. So this is advantaged in a variety of ways, economically, educationally. Another striking feature jumps out, which is that for advantaged Americans, the experience of the US healthcare system is very, very similar to the highest performing healthcare systems in the world on this measure of quality. Whereas for those with more disadvantage, it's dramatically different and dramatically worse. So this also, again, this is not painting a more complicated picture than we might like, but really trying to underscore that these are complex topics. They're a function of social factors and the healthcare system, and we want to start scratching the surface and thinking about these issues. A third thing to note, just before we get into kind of what we're doing today shortly here, is I think a great paper that starts to scratch the surface of what we might learn from other countries. And I want to use this to not say that we've answered this question by any stretch, but to motivate the ideas that we're trying to bring about today. This is some work by David Cutler from a few years ago now. But really what they do is they go and compare the US to Canada. So thinking about comparing across countries, but the interesting thing is that they're not doing that just in aggregate. They're not saying Canada spends a certain amount and the US spends a certain amount more and the aggregate differences are what they are. They actually go into the microdata of how healthcare is delivered. And that's going to be a theme we're really going to hit on today, trying to get inside the aggregate statistics of what's going on. And they break down the differences. And very interestingly, and to my mind anyway, a lot of the gaps come from provider incomes and administrative cost. It's not just that the US is doing more once you're hospitalized. That is some of the gap. But these other features are very big. In fact, when you look under the hood of this provider income differences, it's quite interesting even more. That the provider incomes are different, but if you compare them to the top 1% of income earners in the US versus other countries, they're not that different. So really a lot of the opportunity seems to come from this administrative cost, that the administrative overhead associated with delivering healthcare in the US is much, much higher. And I think this is a very important note relative to a lot of the discussion, but also opens up the opportunity to say, well, how do other countries organize, structure, and administratively run their healthcare systems? That's in many ways, I think, it's by no means easy, but an easier task to deal with than saying something like, we need to have a way of allocating scarce life-saving technologies across people. We could start with arguably lower hanging fruit, which is where does administrative waste come from in the system? And this paper is an interesting example of using data from other countries, really granular data, to start thinking about these questions. Okay. So what is the state of knowledge and what are we trying to do today? Really, there's a huge literature on cross-country health and health spending. And what I would argue, and what really motivated us to organize this conference, is it doesn't really tell us how to solve most of these problems. It says there might be something there. We want to really think about what can we actually learn from other countries. And to do that, we're going to need to really get under the hood. And that's what we tried to do. We put together a conference of mostly academicians in the fall to delve into specific country health systems. And next, we're turning to this conference in which we basically want to put together a set of fantastic panels to deliver some of the findings from that, the key insights, and also really the open questions that conference raised, and to start motivating the conversation about learning at a granular level from other countries and thinking about US healthcare. Okay. What are we going to try to do? Really, we're going to try to support fact-driven discussion. I'm not going to get into the broader context we're doing this in, but often discussion of cross-country health systems are really boiled down to the US is good or the US is bad, and not particularly why. We think that a lot of different countries do very well and very poorly on different aspects, and that there's a lot to learn from that. As I said, we want to move beyond that macro view of US healthcare and flag what we know, and particularly flag where we could learn more. We believe that this is an area that could do with a lot more understanding and research, and this conference will hopefully motivate that. So where are we going? I'm already slightly behind as letting people in the room, but we're going to start with a fantastic panel on national health systems. Then we're going to have a break. We've got breaks interspersed. I know none of you have Zoom fatigue, but some of us do. So we're going to try to break things up. Then we're going to get into regulation and innovation at 10:20 Pacific, and followed by a break. And then lastly, we'll try to bring these together with translating Biden to Biden health policy. So what can we think about in the new Biden administration if they're tackling health policy questions, and close up by 12:30 Pacific. So with that, without further ado, I want to thank our sponsor for this, which is healthsystemfacts.org, but really an organization trying to bring data-driven discussion and discourse broader and more nuanced, and this conference really builds on that. So for those of you who are interested in this, please check it out. It has a fantastic set of information on both US health policy and then across the country. So with that, let me turn it over to our moderator for the first panel. I'm going to stop sharing here and turn it over to Professor Paul Girdler.
Thanks, John. Welcome to this conference. I'm moderating a super interesting panel. And I just want to say that being a colleague of John Kolsted's and Ben Handel's, who run the Gilbert Center, has really added a lot to the intellectual life here at Berkeley. The Gilbert Center is just generating lots of interesting research, interesting public outreach events like this, and providing opportunities to students. So thanks to John and Ben for that. I'm coming to you from UC Berkeley's campus. I'm sitting outside the Sather Gate on a beautiful sunny day. I hope all of you have similar fake backgrounds that brighten up your day. What I'd like to do now is turn to our panel. This is National Health Systems. We have three outstanding scholars who've not only researched national healthcare systems, but also live in these countries and have used those healthcare systems. So we'll get both professional and personal views. Let me introduce the three of them first. And then we're going to run this not as not asking each of them to spend 20 minutes giving us a PowerPoint presentation with interesting colored slides and graphics, but rather as a conversation where they meet the press. And so we're going to try and have interaction amongst them. So I'm hoping we can get everybody on the screen, and we'll work it a bit like meet the press. Okay, so
just briefly, Sung
yeah.
Mai is not in the meeting right now. She is coming and going. She is out of the meeting now.
Okay, well, let me know when she comes back in. I'll introduce her anyway, and hopefully she can join. She'll be able to join us at least by audio in the near future. Thanks, Dana. Okay, so first we have Carol Proper, who's a professor of economics at Imperial College Business School in the Department of Economics, and she was made a dame in this last year's New Year's honors in recognition of her public services to health and economics. Her research focuses on the impact of incentives on the quality of healthcare delivery and health system productivity, and more widely on the design and consequences of incentives within the public sector and the boundary between state and private markets. And then I will note that she has important roles in both the economics profession and as policy advisory. So currently she's president of the Royal Economic Society and also a member of the president of France, Macron's expert commission on major economic challenges. Next on the screen, we have Sebastian Bauhoff, who's a professor of global health and economics at Harvard. He was previously at RAND and a senior fellow at the Center for Global Development. And I know him from really a number of really important articles.
You see me now?
Pardon me? May, you back?
Yeah, I can see you. Okay,
Good.
great.
Good. I'm just about to introduce you. We're live. We had you visually. Now you're just a blank page. I don't think that's true, but okay. So Sebastian, welcome. And then finally, let me introduce Sun Mei Cheng, who is a health policy research analyst at the Princeton School of Public International Affairs. She studies international health systems, and not only is an excellent scholar, but is an important policy advisor in Asia. She serves as an advisor to the China National Health Development Research Center, an advisor to the Center for the Study of Major Policies in China, and was a member of Taiwan Science and Technology Advisory Group in the Office of the Premier of Taiwan on health reform in Taiwan. So welcome to the three of you. And so let me start out by asking Carol, what aspects of the British national health care system really work well and that provide lessons for the United States?
Oh, thank you, Paul, and thank you to the organizers for inviting me, and to the audience too. I think I would list a number of things. One is the UK has a single payer system, which I think really reduces admin costs and makes things easier. Secondly, the UK has no co-insurance for individuals. Individuals are tax funded. The healthcare system is tax funded, which means that individuals bear no financial worries when they are also sick. And I think we see a lot of economics research showing that worries about financial issues make things a lot worse for people. And that I think that's one of the important features of the UK system. The third feature that I'd also say is we have a very strong gatekeeper system. We have a long established general practice family doctor system, which is generally a family doctor system. And everybody is registered with a family doctor. The family doctor is a practice, not just one person generally. with supporting other staff. And that family doctor system means that care in the community is good, very, again, free, accessible. There are waiting times, and then that is used to funnel people into the hospital system. That gatekeeper role, I think, is incredibly important in keeping down costs, and also making sure that individuals who really need care do get care. So I think, very briefly, those three things are things I would cite as important. Single payer, no co-insurance, and a very strong primary care sector. That is a feed-in to the secondary and tertiary care sector.
Great, thanks, Carol. How about that, Sebastian Bauhoff? What are the financing arrangements in Germany? And does Germany have a single payer and a gatekeeper? If not, do your financing and care models differ and function better or worse than the UK?
Yeah, thanks, Paul, and thanks, Carol, as well. You know, the German system is set up differently. We have, for starters, a competitive insurance market in the social health insurance. We also have solo practitioners that are basically independent businesses on the GP side. And so I think our system in some ways has more resemblance to the American setup. So we do have a competitive market. We do have sort of private players in this, at least on the outpatient side. And what I think what's interesting about the German system and maybe useful to think about for the US is, so the core principles, and two of those are the subsidiary principle, which basically means that the government delegates the management of the social health insurance to the key actors in the system, and sort of stays out a little bit out of the management of the healthcare system. And the corporate structure, which basically means that decisions in the health systems are made sort of jointly by the main actors in the system. So there's an association of the health plans, we call them sickness funds, and the association of the hospitals and the outpatient providers, and they'll get together and negotiate. And they'll have to come to an agreement. The government basically doesn't directly set prices. It just sort of sets the framework, sort of stays out of it a little bit. And I think that corporate structure helps minimize, for what it's worth, government interference and maybe sort of short-term political meddling. It also leads to common processes and approaches. So that, you know, if a decision is made to adopt a particular payment system for hospitals, then everybody will adopt that system. There's no sort of, you know, one plan using this particular approach versus another approach. And I think that would be interesting for the US as well, where Medicare, I think, is always sort of the leading light, I guess, what everybody benchmarks themselves to. But in Germany, this sort of all happens at the same time. There's no negotiation between individual health plans and individual hospitals, for example. That cuts back a lot on sort of management and negotiations. And then sort of another takeaway from this basic structure is that all the stakeholders are basically involved and they're sort of dependent on another. They have to come to agreement. It's not that there are no disagreements in the system. There clearly are, and sort of tug of wars. But I think this overall is sort of a sense that we're all in the same boat and need to sort of solve our problems as a health system, and that the government is sort of contributing to that by setting the sort of general structure. Now, I think there are some specific things about the German system that are useful and worth considering for the US. One thing that strikes, I think, many Germans coming to the US is that health insurance here is tied to your employer or comes from Medicare. In Germany, you can take your insurance, move to another employer, or actually move into retirement, and it'll still be the same plan and the same setup. And the benefits and the networks of hospitals and all that are pretty standardized and fixed for everybody.
Thanks, Sebastian. Sun Mei, if you're there.
I'm here.
Great, welcome. Carol Proper and Sebastian Bauhoff talked about really single payer versus competitive insurance, gatekeeper, things like that. I'd like to turn to Taiwan and China-Taiwan and ask you about how your system deals with one of the major issues we have in the United States, which is equity and access to care without blowing the budget.
All right. Yeah, like the UK NHS, Taiwan is a single payer system. and it has guaranteed enrollment. In fact, there's a mandate that goes with it. And it's not a tax finance system, it is the premium based system. So people pay premium every month. And about 99% of people pay their premium on time. So it's not a problem. The way they control cost, well, first, let me just say the spending differential between the United States and Taiwan. The United States is by far the highest spending country in the world by a long shot, 18% of GDP. And the rest of the rich developed nations, their spending is roughly 2/3 of that of the US. But Taiwan's single payer system spends a little over 1/3 of what the US spends. So, I mean, last year or this year, really, because the spending stays very, very stable, it's 6.1% of Taiwan's GDP. And yet 99.9999% of their population is covered. Now, of course, as a single payer, the beauty of single payer, and that is why, you know, as the single payer system was recommended to Taiwan by the Princeton economist Uwe Reinhardt back in the 1989. For this very reason, one of the three main reasons is single payers is a very, very effective cost containment approach to universal health coverage. And so as single payer, the government has wields monopolistic, like a monopoly. It can set prices, and it does set prices, although with inputs and negotiations with providers. So the government sets a spending target each year, and then the providers participate in the negotiation, and then they agree on how they're going to divide up this pie, but not to exceed the growth rate that the government sets. And the growth rate there is pretty much in line with GDP growth, not like in the United States, where health spending growth every year is greater than our GDP growth by 2 and 2.5 percentage points. So first of all, the monopoly power of the government controls spending. But then you say, but then you can control prices. But what about volume? Now, Taiwan has a way to control volume also, which is global budget. In other words, like the NHS, that has an annual budget, Taiwan single payer also has an annual budget that's divided into 5 sub-global budgets, sectoral. You know, there's one for hospitals, one for primary care, one for dental, one for prescription drugs, and one for Chinese medicine. So then all the doctors and hospitals, they operate under this global budget. And if they deliver more services than the budget allows, then the budget reduces. They use a point system. I give you a concrete example. Say for a cataract surgery, say the point, it gives you maybe 2,000 points, which in theory is equivalent to 2,000 NT, Taiwan dollars. But if, say, more services were delivered, then the total points that are available in that global budget, they divide the total volume of services. Okay, you add up all the points that's submitted, and then you divide that by the total number of points available in the budget. And therefore, when the volume exceeds the budget, then the value of your points decreases. I don't know whether that makes sense to you.
Sure.
So that in the end it comes out, you know, total. That you don't have a budget overrun issue. So I would say, you know, in terms of cost control, it's the single payer system plus the global budget system that contains the growth of Taiwan's health spending and just overall health spending very, very effectively. If you look at health spending growth in different countries, again, comparable rich countries, the growth rate in Taiwan's national health insurance is pretty much level, whereas in the US, you see a very upward slope. That slope is really more sharp than the slope in all the other countries. So that explains how Taiwan controls costs.
Thanks. Well, it sounds extremely interesting that Taiwan as a single payer imposes ex ante fixed global budget and has a way to enforce that. In the US, when we talk about these types of rationing mechanisms, budgetary rationing mechanisms, the concern is always raised, well, won't we then be rationing care, or one way providers can stay within the budget is to cut quality of care? How do you avoid that problem in Taiwan?
That is a very good question. Rationing. I would say that in Taiwan, people, first of all, the public is extremely happy. Satisfaction is in 90%. So people say, whatever you do to Taiwan, whatever you do to us, just don't touch our national health insurance. It's revered. And people that there's no limits to how often you can go to the doctor or who you can see. There's total freedom of choice of doctors and hospitals. But I think how they control spending, there are two ways, which is, one is that they limit the number of doctors. See, every year there's a quota. For over 20 years, it's been at 1,300 new doctors entering that market. And the other thing is that the introduction of new technology, especially the more expensive ones, are slower. So there's usually something like a year or two lag in the introduction of new technology, but say in expensive cancer treatments, the delay can be as long as 3 to 5 years. This was according to one of the health ministers I had interviewed, and this is what he said. And so you have these capacity constraint, and then just sort of how quickly do you introduce new technology? But the interesting thing is that Taiwan's health spending is low, really low. And both Uwe Reinhardt and I, we worked together on this, have been urging the government to spend more, because relative to their income, per capita GDP growth is actually at par with that of Germany's, and higher than France, higher than all the Scandinavian countries, higher than Canada. And so they could afford to spend more. So this so-called sort of a hidden rationing, it can go away if they want to, or it can be, reduced significantly. But so far they've been able to get along without, say, a lot of negative reaction from the public.
So like all things in healthcare, it sounds like it's not just economics, it's politics as well. How much do we want to spend? And you have a mechanism for imposing it in Taiwan. Let me turn to the other panelists to get some reactions to these comments. Sebastian Bauer.
Yeah, thanks so much. I was actually going to ask Carol a question, if I may.
Okay.
That is about health technology assessment and sort of cost effectiveness, use of cost effectiveness in deciding what is covered and how to cover it. It's interesting, I think, especially from the US perspective, that it's very strong use of health technology and cost effectiveness methods in the UK. And I wonder what your thoughts are on this, how useful this is, whether it's a big point of contention and whether that's something the US should be thinking about more. Aside from the death panel sort of concerns, I'd be really curious how this actually works in the UK why it might not work, but it does work in the US.
Thank you. And I think it illustrates something that Sung Mei says, that when you have a global budget and that global budget is decided politically, that global budget holds. And therefore, with that global budget, you need to do some kind of rationing. And what the UK did was, rather than having the rationing be kind of ad hoc and meaning something that you had like a postcode lottery as to whether you got a new innovation or not, what they did is they put in a national regulator known as NICE, the National Institute for Clinical Excellence, that applies a cost effectiveness threshold and a quality of life threshold to all new drugs and increasingly medical devices. Now, that interestingly has been a model that a number of other countries piggyback on. So it's obviously not popular with the US pharmaceutical companies. And I mean, there's no such thing as a free lunch in economics. If you're going to have cost control and you're not going to be spending 20% of your GDP, you've got to kind of have some kind of trade-off. And that NICE does do, in fact, what seems to happen in Taiwan too, which is slow down the adoption of very expensive, particularly cancer drugs that have, but they are done on the fact that they have relatively either small number of people that they have benefit, or the benefit in terms of quality adjusted life years is small, maybe 4 or 5 months. That's quite contentious, but actually has been debated a number of times, but as I say, has been adopted by other countries as something, as a kind of model that's out there. It's a bit like what Oregon did many, many years ago, long before the Oregon Health in the 70s and 80s, and that ran into problems politically and was abandoned. NICE, interestingly, has not been abandoned, and it's partly because it has very high scientific input into it rather than government input. It has no kind of public input. There's an implicit value of life, which is around 30,000 to 50,000 pounds a year. So it's lower than perhaps some US thresholds, but that's used pretty consistently in its decisions. Can I also say something that I think that one of the things about the UK system is, because it's got a lot of political support, rather like the Taiwanese system, the flip side that we have is that it's highly politicized. But what I think is interesting about NICE is it's a lot less highly politicized than the system as a whole.
Great, thanks, thank you. Let me turn to the flip side of the conversation so far. Not what do you like about the systems you study, but what cautionary tales should we take from your experience for the United States? And let me start with Sebastian Bauhoff.
Yeah, thanks, Paul. Of course, I should preface this by saying that the German system is actually quite expensive. I think it's the 4th most expensive system, right after the US, Switzerland, and Norway. So it's not that we're such a cheap system, certainly not compared to the UK and Taiwan. But in any case, what I said earlier about the system being a sort of actually set up as this corporate structure and sort of these very strong core principles, it's been very successful and stable. It's been around for more than 130 years and sort of managed to get through in its basic form through 2 world wars and all the rest of it. So it's been very stable, but I think that stability itself is both an asset and also potentially a brake on reforms and innovation. So one concern when it comes to innovations, Germany has been pretty slow to adopting certain types of innovations like electronic health records. There's been some resistance on the provider side, and it's also complicated because we have very strict data privacy laws. But actually, once Germany gets going with reforms, normally things happen in a pretty sort of consolidated and systematic fashion. We now have a Digital Healthcare Act that sort of regulates what kind of EHRs we have and what kind of health apps are available. And now that we have this on the national level, everybody will adopt it. So they're sort of forcing it from the top. They're very slow in adopting these innovations, but once they're adopted, there's sort of a very strong backing behind it, both politically, but then also from the actors in the health system. And so I think the thing that's difficult about the German system is that these innovations sort of come in slowly. They're often a bit more sort of fundamental about, adopting electronic health records, about reference pricing for pharmaceutical drugs that took a long while to sort of get going. And now we have, I think, a pretty solid system of actually doing this. So it takes a while for these things to sort of be adopted. And it's sort of a lingering worry that I have that has not been properly tackled is the financing of the system going forward as the population gets older. We have a bit of a pay-as-you-go system in the social health insurance. And clearly we'll have a lot more older people who might not be working anymore in the next years. And that has not properly been tackled. So that's, I think, one of those things still lingering, but at least on some of these fundamental things like hospital reimbursement systems, pharmaceutical pricing. I think Germany has taken a long while to get going, but once it gets going, it sort of does a reasonable job at this. I think an interesting comparison is the US with the electronic health records, sort of fragmentation in payers and providers, sort of get everybody to adopt similar standards. In Germany, this is sort of done from the top. Again, all the stakeholders in the system getting together, figuring out a solution, but then everybody adopts it. It keeps the administration, the administrative costs and these hassles pretty low. So I think slow in adopting innovations and sort of maybe sidestepping some of these fundamental issues like the long-term financing. Those are my two main concerns.
Carol Proper, what would you like to change about the British National Health Service?
Well, fundamentally, I'd like to change the fact that it's so politicized. It has incredible popularity, the NHS. Reforming the NHS or reducing waiting times in periods when waiting times were high is a sure vote winner. But what it means is that the whole system is A, very politicized, and B, very centralized, because the whole of the UK state is very centralized. We're an incredibly centralized country. We don't have the Länder or other regional political bodies. We're much more like France. Everything in France is run from Paris. Everything in Britain is run from London. And that means that there are 1.3 million employees of the NHS, and often the Secretary of State acts as if he or she is in command of 1.3 million individuals. And that's excluding family practitioners who are independent contractors to the NHS. So it means that you can meddle with the system a lot as the Secretary of State. So there's an awful lot of moving of chairs on the Titanic that happens that's completely unnecessary and generally demoralizes most frontline service providers. So I would like to see a more devolved system in which local regions had more power and indeed providers had more autonomy. There were moves towards that in the kind of the early 2000s, but those moves have been decreased partly as Britain has become more centralized in terms of government. And I think that's a real problem for the health service because it doesn't allow bottom-up innovation to spread upwards very easily. And it allows an awful lot of, as I say, moving of chairs on the Titanic to change administrative structures, which really don't do very much. So it's very open to fads in things like, should we have more competition between providers? Should we have more integration between providers? It's also not very good at things like getting 1.3 million people and an awful lot of different providers to have a single electronic health record system. We do have electronic health record systems, but it would be better, I think, if we had more competing health systems that then you could choose one from. But instead, what happens is kind of one is chosen from the top and imposed on everybody.
How about that, Sung Mei? In England, we're hearing lots of heavy-handed interference from politics to which distorts the performance of the healthcare system. In Taiwan, does government interference? Is there government interference, and does that affect the performance of the Taiwanese healthcare system?
Government interference, depending on what do you all consider interference. Taiwan has a very impressive health information technology system. It's got a common nomenclature, just one system where all the providers are in it and all the insured are in it, and it is interoperable. So now, in terms of how the government's part in this HIT system is that it requires all the providers, doctors, and hospitals to submit on a 24-hour basis, which is on a daily basis, every piece of service that's delivered. And the providers do that. And this gives the government an almost real-time knowledge and image of health spending, of healthcare utilization, and any unusual things that's happening to the health or public health in Taiwan. Like if say that if there's a community spread of COVID-19, they would pick it up within a day, simply because of the surge of admissions to hospitals and visits to doctor clinics. So, but is that interference? I think not, because you can't call it that. And the other thing that I think the government does is it tracks the quality. So because their IT system is so powerful that every billing that comes in goes through an automatic review process. It's like a conveyor belt. You're on that belt and it goes through many checkpoints. And if there's something unusual, for example, the government will know on patient X, how come there are 2 extractions of the same tooth? The government knows that. The government knows which dentist did this and who the patient is. And it'll just kick out this claim and then send it back to the provider and say, please explain. And then, the government also, I mean, in order to control utilization of expensive technology, it does have strict rules about use of MRIs and CTs. But then again, I think it is more in the interest of not just cost control, but also quality, because we all know that there is so much overuse and misuse and abuse of medicine, and especially expensive medical technology. So I would say that, overall, there's the system, it works so well, it's so high performing, that I would say my major recommendation to them would be spend a little more so that you can introduce new technology sooner, and so that you can build up a first-rate long-term care. It's long-term care is very rudimentary in Taiwan as yet. And maybe, you have maybe more nurses I mean, we all know that nurse staffing ratio, how many nurses per bed in hospitals, has a lot to do with how well the patient does with outcomes. And there, Taiwan does, their nurse population ratio, I would say, is on the low side. And they rely a lot on the family to be in the hospital to look after the patients. So it's things like that. But by and large, that system is really very, very impressive because they have, some couple more comments about their IT system. This IT system also tracks, it has the thing called Pharma Cloud. So every prescription any doctor wrote for the patient is uploaded on the cloud. And so when this patient goes to see another doctor or another hospital, the new doctor and hospital is supposed to download to see, what medicine has been prescribed to avoid a duplication of prescription. And since the PharmaCloud implementation, which was something like 5-6 years ago, you can see duplicate prescriptions. There's a very rapid and large decline. And now in the last maybe 3 years, they've implemented this what's called MediCloud. So anything that the patient, any interaction the patient had with the health system is uploaded into the cloud. That includes all your medical history, your surgical history, your dental history, what Chinese doctors you went to, and your images, including dental images, all the MRI and CTs, and all your lab tests. That's all there. It's identified.
Try and get the other panelists in here.
Right. Okay.
Okay,
So you get the idea. Yeah, it's very powerful.
Thank you very much. Let me turn to Sebastian Bauhoff. We've been talking about government interference or regulation in healthcare markets for better or for worse. One potentially positive model is Germany's Federal Joint Committee. Can you describe that and how that might work?
Yeah, so this is basically a committee that sits at arm's length from the government, is responsible for setting basic parameters within the health system. So this is a committee that consists of, has members from the major stakeholders like hospitals, insurance companies, outpatient providers, and is basically where on the federal level, health policy is set for the entire system. And when I say entire system, I mean the social health insurance in Germany, which is 90% of the population. So I think, as was asked in the chat, I think, some features of what this committee does is what MedPAC does in the US already. Sort of it makes some evidence-based decisions, sort of has some considerations around this. And I think this is something that maybe would be of interest to the US to sort of consider maybe more in the decision-making part rather than just an advisory committee. But this committee in Germany, this Federal Joint Committee, actually makes decisions about what happens in the healthcare system. They would decide how to proceed with the, for example, reference pricing for pharmaceuticals, a hospital payment system, and so forth.
Great, thanks, Sebastian. Let me, I'm going to address one question to Carol Proper, and then I have a question in the remaining few minutes for everybody. Carol, the US's approach to healthcare is really very private market driven. We think that for whatever reason, competition solves all ills, and we either sink or swim with it. Could the UK NHS do with a little bit more competition?
Yes, and we've had this is what I mean about periods of policy coming and going, in that we've had periods in which there were more pro-competitive ideas that you could, first of all, to give people more choice. To give people choice. I mean, the kind of, the basic system a long time ago was that you just went to your local hospital and you went to your local GP. That's been kind of modified over a number of years so that people have choice of where to go. And they increasingly have choice of GP, which is incredibly important. Those things are, work that I've done has shown that those things do bring about increases in quality with no very obvious decreases in anything else. So those things have been beneficial to the system, but run within a public healthcare system. And you can see exactly the same kind of reforms, for example, happening in Norway, which is a very similar system that have also introduced more autonomy for hospitals. The problem at the moment is that we are moving away from that, partly for good reasons, to try and link primary care and secondary care more seamlessly, partly to try and get people out of unnecessary secondary care, which we know as health service analysts is a real problem. And Britain is well placed to do that because of its good primary care sector. But that's being accompanied by the fact that there's this kind of thought that what you want is kind of vertical integration, but not vertical integration with perhaps competition between vertically integrated providers. And that's quite a hard thing to do in the UK system. I'm very in favor of having more competition between public providers. I will note that, you know, we do have a small private sector, but demand for that private sector has remained very stable over the last 10 years. And in fact, if anything, has dropped, suggesting that most people do want to remain within the NHS system. And the private sector itself actually isn't very competitive at all. It's rather dependent on contracts at DRG type prices from the public sector. It delivers a lot of elective care to the public sector. That's increasingly its major role. So yes, I agree. We're in a phase where we're moving away from that. And I think moving away from competition, and I think that's not a good idea.
So you see room for competition across horizontal pieces of the system.
Yeah, or across blocks of vertical integrated providers. I mean, the UK is a pretty dense country. People kind of talk about, well, in fact, you don't have much choice if you live in Cornwall. But basically, if you live in Cornwall, you choose not to have much choice about all kinds of public services. You don't have much choice about schools. You don't have much choice about, you know, a whole who provides your local services. That kind of goes with being rural. And the rest of the UK is pretty, you know, pretty dense. It's not as dense as Holland, but it's still a pretty dense country. And in fact, this model, I think, has worked very well in the Dutch healthcare system, where with a kind of social insurance system, they have a lot of competition between hospitals. Those hospitals are increasingly vertically integrated with providers as well.
Great. I thought if you lived in Cornwall, you had to see Doc Martin, but that's a whole nother
of course you do.
show.
Of course. You know, only Doc Martin.
Only Doc Martin. Well, we have a few minutes left, and I'd like to turn to each of you, and I ask you to really limit yourself to 1 minute. The major healthcare crisis every country is facing is the COVID-19 pandemic. And I'd like to ask you briefly how your system has dealt with it, what worked and what didn't. And let me start with Sebastian Bauhoff.
Thanks, Paul. That's a tricky question. I think there's a couple of challenges here. I think on the sort of health delivery side, there's not too many problems, I think, in terms of actually getting the vaccines into people's arms. I think what's been a challenge is procurement of the vaccine. Germany has been slow on this for just a number of reasons that include politics at the European level, but also within Germany, and maybe some sleepiness on part of the federal authorities. I think what's not helping in Germany right now is this sort of federalist system. We leave many of these decisions about lockdowns and so forth to states and lower level government entities. That's recently changed. The federal government now has authority for national lockdowns and imposing lockdowns in different places. But getting there took a year. So I think one of the challenges has been, just like what I mentioned earlier with the electronic health records, a lot of laws and regulations on the books that prevent the system from being more agile. So I think that's kept us from having a faster response. We could have maybe been 2-3 months faster and sort of starting to get vaccinations out. And I think that has been a main challenge. Germany right now, as you might know, is coming out of its third wave. And I think there's hope that the vaccination pace will pick up.
Great. Thanks, Sebastian. Sung Mei, 1 minute.
Taiwan is population almost 24 million, but to date, their total number of COVID cases is 1,154, and total number of deaths is 12. 12 people died. How did they do this? I would attribute that to let's say three big things. The first is that they had a national plan in place. They learned from the 2003 SARS crisis. So they were, every part of this mechanism of prevention and control is in place. Once they detected COVID, which is in early January of 2019. As soon as they heard what was happening in Wuhan, China, they jumped into action. Two is that leadership. There was a national leadership, a very, very powerful and efficient, effective. The health minister sits at the top. He holds the news conference every day and briefs everybody. So there's information, transparency and immediacy. And that worked really, really well. And the third thing is that Taiwan's public really cooperated. If the government says wear masks, yes, masks, everybody wears. Social distancing, yes. And then sitting above all three was this very, very good overall policy, COVID policy that the government set back early January, which is let us keep the virus out. Don't even let it enter Taiwan. And they succeeded in doing that by border controls, which they could do because it's an island. And so with these things put together and with their IT system and with their universal healthcare system, where people have access, not to have to worry about the cost of getting care, COVID care, they have this excellent outcome today.
Well, it sounds to me that we have a lot to learn from Taiwan. That's really, congratulations. What a huge success. And I hope, especially our government in the United States and others, takes the lessons from Taiwan on that seriously. And let me turn to Carol for the final minute.
Okay, so the bad things were we had a government who believe in liberty. So they were slow to enter a first lockdown, and a government also that believes in centralization. So they tried a track and trace system that was never going to work with the British population. We've never been exposed to SARS or MERS. We don't wear masks normally. So that was slow. We also dumped a whole pile of people out of hospitals into nursing homes in which COVID was probably fairly rampant. And these are very vulnerable people. So those are the bads. So it was too much centralization and too much of a libertarian government, very similar to kind of a US approach, very similar politics to a US approach, without the kind of, dissing your major public health officials. They've been on board all the time. The good thing is our vaccination program. We have a very strong academic base for that program. We developed obviously one of the vaccines, and we rolled it out fast because we rolled it out through the NHS. And the NHS at local level knows how to do delivery. So now well over half the population have had been vaccinated. We made a decision to delay time between vaccinations, which seems to be a fine decision, but probably was a kind of a bit of a nerve-wracking decision, but involved, again, many of our leading world virologists in that decision. So I think the other final thing to say is Britain sees itself as an open economy and an open place. And although as an island, I think it could have practiced what Norway has done, what Australia has done, I don't think comparing with Taiwan in terms of the kind of population's appetite for this, I think that was a very difficult thing to do in Britain, even though I think we should have done much more of it, shutting our borders.
Thank you very much. This sounds like really the importance of science-based policy in the vaccination program paid off in the UK. So congratulations on that. Let me end this really fascinating panel. I think we could have easily gone on for another hour or two without interruption. And let me thank our distinguished panelists, Carol Proper, Tsung-Mei Cheng, and Sebastian Bauhoff. I've seen there's been a number of questions in the chat. We'll pass these on to the panelists and let them respond individually. So a big round of virtual applause for our panelists. And then I will turn it back to our host, John Kolstad, to tell us what we're going to do next.
Excellent. Thank you to you, Paul, and to all the panelists for an exceptionally interesting and informative kickoff to our program today. So we have a break. We have a break that's going to go until 10:20 Pacific. I'll let you do the conversions since I know everyone's all over the place. And we'll be coming back after that with a really excellent follow-on panel on regulation and innovation, getting into lots of first order questions about how to think about drugs, devices, and broader innovation of organizational structures. What can we learn for good or bad from other countries? So see you back here in about 10 minutes. And thank you to everyone.